All right, guys, can we get started? Let's see if we can get all righty, chapter 10, right? Chapter 10. Fetal Development and Genetics. Our favorite subject. All right, real quick, you do need to know that pregnancy, yes, it's a very complicated process. Very, supposed to be a joyous one for the most part, but it's a very complex process that lasts how long, the pregnancy?
40 weeks.
40, I'm glad I said 40 weeks, because when Carlos gets a patient in his 50 weeks pregnant, what are we doing with that?
Yeah, we get that baby out.
Okay? Yeah, that's a problem. Okay, so pregnancy should typically last about 40 weeks or 280 days, like it says here. And again, it starts from conception and ends all the way until, the baby is born. Now, you should be familiar with the blueprint. Now, you do not need to know decoding that there's 25,000 genes. I'm not going to test you on that. But you do want to know that those genes do help dictate the parameters such as the traits and any structural anomalies, okay? And when it comes to genetics, it is very important because the vital roles of genetic counselors and nurses play a very important role when mapping risk. They're screening for errors, and they're also protecting and safeguarding the client's rights as well. We're going to talk about that, the client's rights. All right. Now, again, make sure you are familiar and you remember that the average pregnancy lasts about 40 weeks or 280 days from the first day of the last menstrual period. And we're going to talk about that first day. All right. Now, on page, what is it? 278. You do need to know, especially for the next upcoming assessment, the stages of fetal development. Yes, that will be on your next test. The stages include pre-embryonic stage, where you see fertilization taking place up to about the second week. And then next you go into the embryonic stage, which takes place between weeks 2 and 8. And after which you see the fetal stage, would take place about the 8th week up until the birth of the child, right? You also should be familiar with all of this englobes fetal circulation, which is a very important aspect for fetal development, which goes through and you'll see circulating throughout all the stages of fetal development. Very important for you to know that. All right, it's gonna come up somehow. Also, you do need to pay attention to box page 281. You see that box, or that not box, but that table, 10.1? No, not bottom left, that entire page. Okay? On page, oh, I'm sorry, I said 281, it's really 282. I apologize for that. 282.
Okay.
That right there.
Yeah, that's a big box.
Yeah, good. Okay? You do need to 10.1 as well, the summary of the pre-embryonic development. You do need to know that. I don't know why I skipped that, because I'm going to put that on the test anyway. But this right here, when things happen, you need to know. You need to know. You need to know. For example, week 3 of gestation or fetal development, you see the neural tubes are forming. That's when the heart is starting to take place, the GI tract is starting to develop. That's on week 3, and then maybe around week 13, you see the skin is almost transparent, the bones are becoming harder. You see the baby is starting to make sucking motions, it's sucking their fingers, generally it's the thumb, okay? You see the formation of the pinna, part of the ears, etc. And then also week 13, external genitalia usually is recognizable. Hint, 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 hint. Okay? So yeah, know this box. Fall in love with it. Okay? Up until you pass this class. Okay? Because they will come up periodically. Alright? So know that. Moving forward. Also, on 280. On 280, you do need to know for this next exam, because I don't think I put it on the other ones. I don't know. But this next exam, you do need to know the layers of the embryonic, the 3 embryonic layers of the cells. Ectoderm, mesoderm, and endoderm. You do need to know that the ectoderm, this forms the central nervous system, which includes like the senses, the skin, and the glands. The mesoderm, this is where you start to see the skeletal, urinary, and circulatory, as well as the reproductive organs taking place. And in the endoderm, this is where you see the formation of respiratory system, the formation of the liver, the pancreas, and the digestive system. So those 3 layers are formed at the same time as the embryonic membranes are all formed as well, in addition to the tissues, the organs, etc. All right? And that's what you see on that box 10.1 that we said you gotta memorize. We cool on that, right? No, don't give me headache, Daryl. Don't give me headache. Don't give me no headache. You do need to know the timeline of fetal maturation, okay, or organogenesis. So when the organs are taking place, all right? That's basically, again, the same table that I was talking about, 10.1. You want to know, again, when does anything is in the baby's with regards to fetal development, all right? For example, week 5, the heartbeat starts to take place, so you can start hearing heartbeat. If this client says, oh, I'm only 2 weeks pregnant, but then yet you could start hearing fetal heartbeat, you know that there's a discrepancy. You understand? So that's why it's very important for you to know, give or take, when does things start to take place. Now, I will warn you, for this upcoming assessment, we're going with this for now. It does change in the future. Okay? We'll do it when we get to that bridge, okay? But for now, just we're going with this. Because there is a very slight variation. It's not that crucial. But when we get to that changes in the future, we'll address it then, all right? But for this upcoming assessment, know this table. We're going with the information on this table. Okay? One color? Yeah. You know, you're never gonna forget your name, bro. Alright, next, amniotic fluid. You do need to know this up until you take and pass NCLEX on the very first attempt, because it's very important. What is the amniotic fluid and what does it do? Drew. Yes. Drew. You speak Spanish, right? You're not like Juan Carlos. Huh? She's claiming it. She's claiming that. Alright? Amniotic fluid. What the like your tea, girl. Alright, let's go. Amniotic fluid. What is it?
I know it provides like comfort and like placing like bouncy cushion for the baby in the sack, right?
It provides comfort to who? The mom?
To the baby.
The baby. Okay. So what is it? You told me what it does, but what is it?
It's fluid.
It's fluid. Okay. This is like a swimming pool for the baby, if we can say. All right. This is what the baby is like in their world. All right. And like you said, it does protect the baby. Like we said, you do need to know it does surround and protect the developing baby in the womb, and it does increase during pregnancy and reaches about 1 liter. Okay. Once we get full term, it is very important that you know it does get to about 1 liter, because if the physician or the healthcare provider who does measures that amount of fluid and find it to be less than I believe 500 or more than 1,000, it's a problem. Okay, it's a problem especially for the fetus, but both mom and fetus could be in danger. Okay, so it should be about 1 liter by full term. It helps keep the baby temperature stable. It does allow the baby to move and swim. No, they're not swim, but move freely. Grow as well. It cushions the baby. It is mostly water. This is what I want you to know. You see how much I like y'all? It is mostly water with small amounts of waste and proteins. You see that? Now play with me. All right. Now, where does it come from? The mother's blood and baby's pee-pee. Okay? That's all it is. Mommy's blood, baby's urine. That's what it is. All right. And it also the baby swallows and replaces the fluid constantly. Let's consume a little bit of that. All right? Yes, okay. What do you see in this? You do need to know the content, especially for this upcoming assessment. It's composed of 98% water, and then of course 2% organic matter, which can include albumin, uric acid, vernix, fine hair, so on and so forth, bilirubin, etc. And it's very important, again, like I said, for fetal growth. Like I said earlier, the amount, you see what I said? Too little can cause growth and lung problems. Too much of this fluid, which is known polyhydramnios, don't judge me, okay, can lead to preterm birth and delivery. Yes, I do want you to know the medical jargon. Okay, now are you going to say, oh, you have polyhydramnios to the mom? No, okay? But when you are interacting with other disciplines such as a physician, when they do state this, then you need to know what they're saying, okay? Poly and oligo. Be familiar with your root words. Let me say that again. I'm going to pause right here. Be familiar with your root words or your medical terminologies. Poly, anything you already know is too much. It's a lot going on. Okay, more than what we need. Oligo, means, yeah, because y'all did med surg already, no? Oh, you're going to do med surg. What you did fundamentals? You did oliguria. I know that because I teach that class, okay? See that? So, all right, I gave you a little bit of gem right there. All right, next, what you need to know moving forward in the interest of time is what happens in the placenta. You see this information right here? You see let's go high, don't play with me. 284. Because Daryl don't want to carry his book. Neither does Juan Carlos.
We didn't know.
I know.
I'll bring it next week.
I was getting on them too. You said she put herself out there.
Don't let him take all the.
It's okay. Page 284 when you go home. 284. This is the part that I want you to make sure you pay attention to, and you definitely are not playing with me. The placenta. The placenta. Okay? What's in the placenta? It has one large umbilical vein and two small umbilical arteries.
Ava.
Ava.
Yep.
Yes, that's right.
Ava.
Yeah, we know Ava.
Professor James. Professor James.
Professor James, I hope you're listening. Okay, giving you credit. Okay? Explain Ava, because I need to use that and show out for the next class so I can act like I knew something.
2 arteries, 1 vein.
2 2 A's in the V. Okay, I got you, Ava. I like that. Okay, I'm gonna claim it, okay? Just for that. Just for, all right, very good.
So if for Virginia, it's not it.
I like that, okay? Very important. Guys, this is listed for you on page 284, and I put that up here somewhere in this slide, okay? You also need to know the umbilical vein. It carries the oxygenated blood to the fetus, while the arteries transport deoxygenated blood with waste products from the fetus into the placenta. Okay, so don't only know there's 2 arteries in a vein, which is very important for you to know. Also know the contents of what the purpose they serve. Okay, not I said contents, but the purpose that they serve. Okay. Now, the structure, the placenta is usually fully developed and well structured by week 12, and you also have, as indicated on page 284, this thing called the Wharton jelly. You should be familiar with it as well because it can come up. See it a lot of in NCLEX reviews. This is why I'm stressing it. Wharton jelly, which is basically a special type of connective tissue. That's all it is. Okay, Wharton, WHARTON. It's in the middle of the first paragraph on the right-hand side. This is basically special connective tissues. It surrounds those three vessels in the umbilical cord. And all it does, well, not all it does, but what it really does, like it says, it prevents cord compression, which would cut off fetal blood and nutrient supplies to the fetus. So it's a very important tissue, okay? All right, and then of course, like we said earlier, the placenta serves to protect attack by the pregnant mom's body, and it also, which why it brings more food to the placenta. Okay. I also want you to be familiar with the hormones involved that produces the HCGs. You guys did the different signs of pregnancy, probable.
No, nothing.
We read about it.
We're just now getting
If you're
into
the-
pregnancy. I mean, we're still learning all of this. Yeah.
Okay, we'll get to that. All right, another time. Just read the probable signs. I'm not gonna put it on next test, but you do need to know it, okay? The probable versus presumptive, yeah, and positive signs. Yeah, okay, make sure you're familiar with it. All right. Why I bring that up is because HCG levels is what you find in pregnancy is not a positive sign that you are actually pregnant, right? But what you do see in the placenta, it does carry that same hormone HCG. That's why I brought it up. Okay, but we'll cross that bridge another time. It's raining, and y'all know when it's raining, ain't nobody trying to be out. Anywho, teratogens. What does teratogens mean? Okay, all right, I'll go try to walk to somebody with that.
Unalive a baby.
Unalive the baby. Yes. What can serve? Ooh, what can Juan Carlos? I don't know. I just like calling your name. What can serve as a teratogen?
Some medications, right?
Right? You asking me? You telling me? Okay, I'll let you say. You are right. Okay, do you know what medication? That's a foreign semester, so you should know.
Oh my.
Yeah, that's a foreign lesson.
Ongoing pregnancy, yes.
You know what? Can you give her a drug? One drug?
TCA.
Thank you, Line. Okay, all right, okay, all right. We're gonna keep it moving this time. Okay, teratogens. You do need to know, yes, it's something that can harm the baby, and there's different types. You have the physical agents such as radiation, for example, which can serve as a teratogen. This is why we don't want to expose mom to certain diagnostic procedures unless the risk outweighs the benefits. Y'all get what I'm saying, okay? The benefit outweighs the risk, yeah, okay? Then you have metabolic conditions like maternal obesity, diabetes, hypothyroidism or low thyroid or PKU. Y'all better be familiar with PKU because you're gonna see it a lot, okay? It's gonna come up a lot. PKU, that can also serve as a teratogen as well. You have chemical and drugs like Juan Carlos was saying, certain drugs like anti-epileptics. Now, let's say a mom, since I took pharmacology last semester, okay? This young woman is on an anti-epileptic drug. Give me an anti-epileptic drug. Juan Carlos. Up there.
Would that be the same as
Yeah. Juan Carlos. Okay. I got a long Juan Carlos tonight. Let's say this young woman has been taking Keppra. What's your name again? I'm sorry. Lydia? Lita, since you gave Juan Carlos the answer. Mm-hmm. Can you stop this medication abruptly? No, but she's pregnant. But that medication could serve as a teratogen to the growing fetus. What are we gonna do?
Paper?
Did you say rock, paper, scissors?
I said paper.
That should be a test option. You know what? Rock, paper, scissors is an option. Okay. No, I'm just messing with you. Okay, what you said taper? Yes. Okay. Now, again, it depends on the severity of the seizure as well, because some of them, some clients, they can't be tapered as easily as the physicians would like to, so they're going to again outweigh the risk versus the benefits. Some are going to be discouraged to even continue on with the pregnancy. It does happen. All right, so you need to know, this is why you do, from first semester we learned this, med reconciliation. To see what medications has this client been on and which of these medications can pose a threat to this growing fetus, right? Anti-epileptics is one of them. Keppra, phenytoin, carbamazepine, etc. You have large doses of vitamin A, large doses. If I just put under scenario vitamin A consumption, you're taking vitamin A one pill a day, that is not a teratogen. But if it's on there like, oh, this client has been known to take 20 pills of, vitamin A, something drastic, then we have a problem. Does that make sense? Okay? Anticoagulants. Some clients need to be on anticoagulants. Okay? But again, now the danger is for the growing fetus. What do? Can we taper? Can we put them on again, because heparin, like anticoagulants like heparin, you have to monitor the INR levels, for example, and we can see how we can safely either try something that is safer for the growing fetus if mom still needs the anticoagulant, or see how can mom be tapered away from that medication at all, okay? And then of course, tetracycline is another one. You have different infections that also can serve as a teratogen to this growing fetus, like toxoplasma, syphilis, rubella, CMV. Do we know how we get CMV? I never heard of CMV in my life.
Antibiotics?
What is that?
CMV is an antibiotic?
No, it's from an antibiotic.
Cytomegalovirus? I guess I
not.
found my own new homework. I guess we found our new homework. Hey, you see? Bam! CMV. CMV. There go homework for
Close contact with infected body fluids.
Whoa. That is not CMV. What is CMV?
It's an incurable virus related to the herpes family.
Y'all don't want homework? Y'all gonna have to study it anyway. Jeez. Fact check that, Juan Carlos. What is it?
It's an incurable virus related to the herpes family.
How do we get it?
Close contact with body fluids.
What Sam said.
Okay, I was trying to. All right, I'll find another homework assignment. Daryl too happy. So infections can also serve as a teratogen. Okay, so again, make sure you know the different types of teratogens and the examples that fall under those teratogens. I put here for you gestational weeks, embryonic stages. These in other words, the teratogens are more likely, or the fetus is more susceptible to these teratogens during weeks 2 through 8 is what I'm saying right here, okay?
For all four of those categories?
For all four, yeah, okay? And then, again, the fetal stages does occur weeks 9 through 38, but it's very, very vulnerable weeks 2 through 8, okay? All right, what next? What's my thing? You keep it moving, because this rain is not helping me. I'm trying to stay away, people, for you all.
This rain better let up.
I know, right? You also have to deal with the issue of fetal circulation. Blah. Okay, on page 286. Okay, on page 286, you have, I talked about the amniotic, it's talked about the amniotic fluid, how the fetus gets oxygen and nutrients through the placenta. Talked about. Now also know again the fetal heart rate begins forming around 22 days after conception. Now the main thing that I do want you to get from this is the shunts, because you will be tested on this on either the upcoming assessment or the one following, but also the you also need it for NCLEX. There are 3 main fetal shunts you have to be familiar with, and I put them here. You have the ductus venosus, which basically connects the umbilical vein to the inferior vena cava. cava, and it goes over or bypasses the liver. You have the foramen ovale, and these are stuff that you're going to need to know for pediatrics too. The ductus arteriosus, Lord have mercy, okay, which basically connects the pulmonary artery to the aorta. The importance of the shunt is basically it helps with transporting oxygen-rich blood to very vital organs such as the brain and the heart, right? So, and also you see different hormones are being circulated around, such as prostaglandins, which basically keeps 3 temporaries open to direct the oxygenated blood straight into the brain and the heart. This is what I would need you to know, okay? Very good. They're gonna keep it moving. Boom. Now there's the issue of genetics. You may, at some point, depending on where you go in your nursing life, be a counselor and specifically a genetic counseling, deal with genetic counseling. Basically, this refers to the study of hereditary, where you are concerned about genomics. And with regards to genetics or genetic counseling, there's an issue of the amniocentesis being studied as well, okay? Amniocentesis is that diagnostic test that confirms if there's any issues with the fetus or abnormalities specifically, okay? Such as with the fetal developing fetus, like do they have like Down syndrome, etc., okay? Now, nurses are required to have basic skills and knowledge in genetics, genetic testing, and genetic counseling, because this is how you're going to provide accurate education. If you don't know nothing about genetics, how you going to provide accurate education? All right? This is the main thing that I need you to know with regards to genetics from that section. And then with regards to the autosomal inheritance, I don't really like it, but you have to know it, okay? Because again, this comes up in a lot of NCLEX reviews. And some students actually may get tested on this on NCLEX, all right? The issue of autosomal inheritance. Now, when they talk about the autosomal dominant, okay, this is where you have a single gene producing phenotype that shows you the physical characteristics of that that fetus or that individual, okay? 50% is, they have a 50% chance of, if the one person of getting this genetic disorder, if one person or one parent is affected. There is an issue, there is a possibility, I should say, of male-to-male transmission. In other words, father transmitting this genetic disorder to the son, okay? What else? So there's some examples of an autosomal dominant disease: neurofibromatosis, I don't know why I would choose the words I definitely can't pronounce, but Huntington's disease, Marfan, etc. These are some examples of autosomal dominant diseases, okay? Then you have autosomal recessive. Now let me tell you, your book goes into a lot of them. Only the ones that's on these slides is the one I'm testing you on. Anybody got time for that, okay? Listen, autosomal recessive, this is where you see 2 abnormal genes and both parents have to be carriers of that disease, all right? The individual has 25% of being affected. You have also a 50% chance that there's a carrier, 25% if there's disorder free. But the risk increases with consanguinity.
What does that mean?
Well, I don't know. Juan Carlos, we don't know what that means. Juan Carlos. Juan Carlos like, oh, we need to know, what does this mean? Juan Carlos like, I don't know.
The state of being related by blood, meaning 2 individuals share at least one common ancestor.
Thank you, Dr. Google.
I'm known to be Google.
What does it mean?
The state of being related by blood, meaning 2 individuals share at least one
Okay,
common
I'm gonna show y'all how y'all, where my Latinos at?
Oh.
Hello.
No, because I'm looking at this with, is it incest?
No, that's not what it is. No, you see, sang, blood,
Yes.
con, okay, con
With.
is what?
With.
With, so
With
blood
blood.
related. Is that not what you just read to me? What is consanguinity?
Yes, blood related, yes.
That's what I'm saying.
It's kind of like incest.
It is
They
incest.
like if it's two cousins being married.
Yeah.
Oh, my bad. Well, yeah. You know what? Hold on. Wait.
No.
Read it again. Let me make sure. Hold on before I get you. Read it again.
The state of being related by blood, meaning two individuals share at least one common ancestor.
Yeah, one common
Okay.
ancestor.
One common ancestor. This is not when, okay.
A
Yes.
classic example is a marriage or union between first cousins because they share the same grandparents.
Yeah.
That's incest.
It is, yeah.
That's like backwards fucking.
Yeah. You not even think about it, but yeah, it is that. Hold on, listen to this.
From the book, it says affected people are usually present in only one generation of the family. Females and males are equally affected. So it says also that it could be where they both have like abnormal genes. They
Both parents
Yeah.
have abnormal genes.
Yeah, both
And that's how it's like, if both parents have abnormal genes, then the child is most likely to get this disease.
Exactly, mutant genes.
Mhm.
It's a couple contagious or consensuous.
Yes.
So both parents probably have like a certain gene, and that's how the child will happen.
Okay? So basically, again, like what she's saying, if both parents are carriers of this genetic mutation, each pregnancy,
Oh, that's probably what they mean by the same blood.
okay? Each pregnancy has a 25% chance of having that, of having that child having that disorder. There's a 25%, right? Or there is also a 50% chance of that child being a carrier. And there is also a small percentage or 25% chance of that child not affected at all. Just a 25%. Okay?
It's important to know, like,
Who you marrying?
get married to and how to
Yeah, buddy. Okay. All right. So again, just know for the most part that the example of autosomal recessive is cystic fibrosis, PKU, Tay-Sachs disease, even sickle cell. This is why I encourage you, for like you were saying, if two parents before they get together and fall in love, let's see what
Your grandpa, my grandpa?
Yeah. Let's see if we're not related, first of all, okay?
Well, how do you think people were even like created back in the day? That's
Well,
all you had was your sister, your brother, your cousin, your.
Well, not no more.
But not no
Not no
more.
more, I'm just saying.
Well, we should say it shouldn't be anymore, but it still does happen these days, though. It still does happen. What you call it, backyard cousin? What you said? Back. All right. The other genetic disorder you need to know: the X-linked recessive and the X-linked, where it affects where the carrier female is affected or where the male is affected. Okay, let me talk about that. In other words, it's talking about what's happening with the chromosome, specifically the X chromosome. Okay, it is very common, but just know that with regards to the X-link, for test purposes, if there is an X-linked recessive disorder, just know that it means that there's a 50% chance of the son or the male child being affected, or there's also a 50% chance of the female child being a carrier. That's all I really need you to know, okay? Because it's a lot of math and it ain't that serious. X-linked recessive, you should know there's a 50% chance of the male being affected, 50% chance of the daughter being a carrier.
We got carry everything.
Yeah. Hence the X-linked recessive issue, okay? All right. With regards to the male, now if there is X-linked recessive with effect of the male math, 100% of daughters are going to be carriers, and 0 male-to-male transmission. In other words, 0 chance if it's a father having it. There's a 0% chance of the father transmitting it to his son. Okay, but daughter, yeah, might have it.
So the son got 50% 50% chances of being
Being-
affected, but we get a whole 100%.
Bruh, it's bad enough that we have to suffer for 9 months, you know, and, you know, go putting men on pause and all this stuff. But hey, you know, we don't go through enough. We don't go through enough, you know? Oh, yeah, okay. All right, look, one corner's like, I'm just trying to pass the class. All right, guys, let's move forward. The only thing for this slide that I need you to know, the chromosomal abnormalities, is that it does affect very few. Don't worry about 1 to 2%, but it's just know very few births are affected, which does not follow a very straightforward inheritance pattern. If the anomalies does occur after fertilization, it can result in mosaicism. I don't know what that is. Juan Carlos?
No, that's.
Okay, but this is where you need to call your assistant. I don't know the names for
Girl,
real.
what is it?
I don't think she have to ask.
Mosaics, that one.
Yeah.
Hurry up because we gotta go home.
It's left. It's a genetic condition where a single individual possesses 2 or more genetically distinct sets of cells in their body.
Okay.
Yes, because what?
Mm-hmm.
Yeah.
Yeah.
Like Down syndrome.
Because you read something. I will be honest with you, what you read barely went in one ear.
It means a person has 2 or more different sets of DNA inside their own body.
Say it again.
A person has 2 or more different sets of DNA inside their one body.
You only got one body. All right. So again, the main cause of that is because of abnormal cell division, or like it says here, non-disjunction during cell division. You have the monosomes and the trisomes. Monosomes is where the entire chromosome is missing. It's rare, but not that it's rare. Rarely survive to term. In other words, it's rare that this fetus will come out alive or make it to the end of pregnancy with the monosomes. Now, with the trisomes, this is why genetic counseling is important. With the trisomes, this is where there's an entire extra chromosome, hence trisomy 21, Down syndrome, trisomy 18, etc. That's what happens, and what you have it with this is those type of diseases like Down syndrome, etc. They will live, but they will live with some sort of abnormality. Okay, that's what happens with numeric abnormalities, errors in the count. And then with here that I put here, the structural abnormalities. In other words, how is it assembled? How is it structured? You have, for example, broken ends are rejoined incorrectly. Okay, so it's supposed to look like this. So instead, you got this broken end attached to another chromosome. All right. So different types is where you have deletions, duplications, inversions, such as it's upside down. Is discombobulated in that way. You have translocation, which basically means it's exchanged with another chromosome. So that again produces an abnormality within that fetus, right? It can be balanced. There's no loss or gain, okay, when it can be balanced. Or if it can't be balanced, this is where that fetus can suffer severe consequences. They may live, but they may have a poor lively outcome.
Kind of exactly, like what would they have, like to their immunity?
Oh, I don't know. I don't know. Let's find out. Hurry up. Because I'm not Juan Carlos. Juan Carlos, you do know you have an assistant, right?
Yeah.
Okay.
What are we looking for?
Wow. Wow. We want to know when it's unbalanced, when the chromosomes are unbalanced, right? What are the severe consequences? What's a example of disease process? Sorry, we have an assistant who's raising her hand in the back behind you.
Cry do chat syndrome. Infants with this condition have a high-pitched cat-like cry due to laryngeal development issues.
Oh, it's really cry do chat?
Yes, ma'am. Along with intellectual disabilities and delayed development, because it's caused by a deletion on the short arm of chromosome 5.
So the chromosome 5 have a short cut in half.
And then they start crying like a cat.
Because you cut the tail off.
You cut the yes. Okay. Now, for test purposes, I'm not gonna put the example. I just need you to know what happens. Okay, for testing purposes. But good question. Okay. All right, moving forward, so we can get out of here. I keep saying we're gonna get out of here, and we're not. All right. Just know about 10.2 on page 295 or 294. Let me see. 95 on the book. Okay. 10.2, those who may benefit from genetic counseling, you should know this, because it definitely does come up. Maternal age, now, I like how they said, they call it, what they call, geriatric birth? Geriatric pregnancy, yeah, that's an appropriate term, geriatric pregnancy. Once you start getting pregnant after the age of 35, you're geriatric.
And I got one more kid left in me, y'all.
One more kid left in you. You pregnant?
No.
Oh.
No.
I was about to say it. Look at my glasses on.
Just saying, I want to have one kid.
Oh, and you getting up there?
Oh, and I'm already up there.
Oh. Nah, does that mean
I'm surpassed there.
really? You don't look it. Oh. Now, does that mean any female who gets pregnant at the age of 35, their baby gonna come out discombobulated? No, but the risk is there, is higher.
My mom
Okay.
had my sister at 43.
She had you at 43?
She had my little sister. My sister's 14.
And anything wrong? See, perfectly fine. Now, what you will do, honestly speaking, seriously, your education is going to be very vital. This is where you're going to educate the risk factors, but you're going to tell them what they can do to minimize those factors. Eat right, exercise, balance your stress.
I mean, they did tell her, like,
Yeah.
the risk and outcomes. And
Yes.
she had to go see, like, doctors, specialists.
Specialists. And now, I don't know if you did this earlier, but you should know when the checkup should be, right? For a normal pregnancy, the first trimester, I believe, is every 4 weeks, right? Every month. And then it increases as you get closer to, I think it's
every 2 weeks.
okay.
It's every 2 weeks.
However, for those who are at higher risk for some type of abnormality, the frequency increases, right? It might be every week.
It was. I was taking her to West Palm every week.
Every week, so you understand? So that's, you should know, okay? All right, good. What I was saying, box 10-2, that's what I was gonna say. Maternal age, 35 or older, pregnancy screening abnormality. If you have a previous child with a genetic abnormality of growth, so you need to know who would you counsel on genetic, all right? And who may benefit from genetic counseling. All right, moving forward, what I said here. Just know that know your role in terms of genetic counseling. We are, especially as nurses, we are helping the client to, prioritize, well, let me say this. As nurses, we have a very important role when it comes to genetic counseling, okay? This is why collecting data is very, very essential to the patient care and the outcome of their care. So you want to gather your information, okay? Gather as much relevant, pertinent data as possible. You want to make sure there's this issue of the privacy challenges. Basically, the pedigree frequently reveals heavily guarded family secrets. So they don't want to share nothing, so that's why they might not want to even have this done. Okay, so that can be an issue. And there's also the issue of ethical mandates or there could be ethical conflicts at play. So strict maintenance of confidentiality and patient privacy is paramount. Protection from workplace and insurance discrimination is partially addressed by genetic information non-discriminatory. So in other words, just because you have been found to have a genetic anomaly or risk factor, you shouldn't be discriminated against for health insurance coverages and stuff like that. But it can cause some drama too in family. Just be prepared for that. All right, this is pretty much self-explanatory. The nurse's mandate, making sure the practice that we provide is evidence-based. I already talked about providing holistic care. That's what we do. Providing genetic counseling, yada yada. And we are done. What time is it? It's time to go. I'll see y'all when I see y'all. Maybe next year. No, let me stop.
No, we just got you.
Yes.
Can you link that to like
Yeah.
the Blackboard?
Yes, that's why I put it right there on YouTube. It works, and I think I have to wait for it to, let me,